Thank you, Ashish, for giving me this important topic. When I first saw the topic that he has given me, I said, Brutus, he is putting me into the most controversial of the topics. But I think I should be able to present before you the evidence that is there and the best practices that we could possibly follow so that we perform this injection in a very safe way. Now, most of the other injections, for example, revolutionized the treatment of exudative macular diseases, and the only FDA approved, or rather a couple of FDA approved anti-VEGFs that are there, are not really accessible to most of our population because of economic concerns. Now, all of us ophthalmologists have been trusting Avastin or bevacizumab because it is giving us almost equal results, and the safety concerns are also not that great. Now, in the absence of a proper formulation from the company that makes bevacizumab, it does not give us single dose vials for ophthalmology. We rely on using a non-optimal formulation that was meant for cancer oncology use, and we try to use it in the best possible way to benefit our patients. Just to give you an idea of how much everybody wants it to be safer, this was a survey of about 114 RetNet India members. RetNet India is an informal group of retinal specialists, and where we asked a question that would you prefer if Avastin was available as a single-use syringe directly packed from the company, and a resounding answer was yes. So the quest for us is to make affordable treatment available to the patient while ensuring the safety. Now, what are the issues in using a vial, a single dose vial meant for single dose, as a multi-dose vial for longer than it is actually labeled? The vial is labeled to be used only for 6 hours once it is opened, not more than that, but we are using it for much longer. So what are the issues? We need to be sure that the drug is stable. It does not degrade. The quantum of drug that we are injecting is the same that we intend to. Is there any alteration in the structure of the molecule on storage? We also need to be worried about the safety. Is there any microbial contamination? Is there any non-infective contamination? And what is the legal perspective behind it? So I will be touching all these topics one by one. Now, when we come to stability, there are now enough studies. There are almost about 7-8 studies which have proven that Avastin is a very safe drug. At a variety of temperature and conditions, which includes repeated freeze thawing, it is still stable. When you store the drug, an open drug, for 3 months at 4 degrees centigrade, that is the intended temperature, there is only about a 10% reduction in the activity. So when you are giving 1.25 milligram, you may actually be giving 1.1, that is also at the end of 3 months. And this is the same regardless of whether you store it for 6 months or whether you store it for 9 months. There have been studies up to 9 months which have said that the concentration doesn't really drop too much beyond that. The company markets the vial and writes that you have to keep it away from light. So there are people who have done these experiments when they have exposed the vial to light versus kept it in the dark, and they have not found any significant change in the activity of the drug. And even on repeated freeze thawing, accidentally you may freeze the drug in your refrigerator, and when you thaw it, you may be unsure whether we can use it or not. Now, there are studies which have frozen and thawed the drug for 6 times and have found only up to a 15% decrease in the drug activity. So one question answered, yes, it is stable. You can use it for longer than it is intended. What about the other aspects? Does the structure of the drug change? What they found is that when you segregate it into syringes, when you aliquot it into syringes, when it passes through the needle, there may be some aggregation of the smaller molecules into larger molecules. Now, this has not been proven to affect the activity in any way, but some have postulated that it may result in slightly higher risk of complications, that is increased intraocular pressure, because these larger molecules may block the trabecular meshwork. However, no clinical study has proven that. Now we come to the most important concern which is in the back of our head, that is the safety. Now, there have been a series of outbreaks of endophthalmitis when Avastin has been compounded in pharmacies and used over a variety of places. Several of them were in the US. 2 of them, the most, rather I should say, infamous ones were at the Veteran Affairs hospitals, 2 Veteran Affairs hospitals, and after that, the FDA issued an advisory on using these drugs. Now, when I talk about safety, I am not talking about end-off can happen because of a faulty procedure when you have contaminated during the process of injection, or it can happen because of microbial contamination prior to the injection. So that is the topic that I would be touching at. So during preparation, there can be contamination. Now that could give you very, I should say, unexpected result and lead to potential loss of existing vision. And this kind of infection is usually more problematic to handle than infection which occurs because of contamination at the time of giving injection, because when a vial is stored, the bacteria are multiplying. So the inoculum of injection, the inoculum of infection or microbes that is entering the eye may be much higher than what you would when you are giving the injection. In the US, the people are lucky; they have an organization called FDA, very strict. In the Godfather movie, Al Capone said, not the Godfather movie, Al Capone gangster said that you can get cooperation with kind words, but if those kind words are coupled with a gun, you get even better cooperation. So in the US, they have these guidelines for compounding pharmacies which are strictly adhered to. And the effect of not following these guidelines is very severe. Unfortunately, in India, we do not have any such guidelines or a regulatory body that can have a oversight or any legal action that can be taken on a compounding pharmacy. We don't have on-site monitoring or off-site monitoring. The compliance to protocol, most of us will not be aware of. Coming to the other aspect of safety, fine, we made sure that there is no microbial contamination of the aliquot, but is it safe otherwise? Most studies that have studied the drug after compounding have found the presence of silicone oil bubbles in the syringes, and that is usually related to the lubricant that is part of the syringe. Now these are sterile droplets. There have been several reports. They do not cause any problem as such. The other aspect is endotoxins. Now some of these syringes have been sterilized, and they may not have active live bacteria, but they may have endotoxins still. Now these have been postulated to cause end-of-life reaction. Usually it is self-limited, usually a very aggressive treatment is not required. And there have been several outbreaks of this nature reported in literature. Now let us come to what are the methods that most of us employ to use the single dose vial of Avastin. Aliquoting into pre-filled syringes, either done yourself or at a compounding pharmacy, is the most common worldwide. In India, the most common is the multiple puncture technique, using a single vial, using multiple punches to take the drug out of it. The other practice that a lot of people follow, especially in institutes where the large volumes are there, they pool patients on a single day and then give the injection. So in the survey that we did on the RetNet India, we found that almost 50% of the retinal surgeons in India use the single vial rather than aliquoting it into multiple syringes. And institutional people used to use, either pool patients or a large percentage of them would aliquot them into syringes. Usually private practitioners are not doing that. Now let us come to the script of the movie. What all of us should follow when we are basically using a single dose vial multiple times. The basis of that is the US Pharmacopoeia, chapter 797, which describes the conditions under which these sterile preparations can be used more than once or can be aliquoted into multiple doses. The first and foremost important, it's a very large chapter, so I've just taken out the very few significant points that are relevant to us. The first point is that any aliquoting or multiple use from a vial should take place under class 5 conditions. Now class 5 condition means that there are only 100 suspended particles in 1 square feet of air. So that is a very difficult task to achieve, and I am sure that none of our OTs is able to achieve that. That is less than 1 colony forming unit per meter square. Now that is something which most of us don't have. It is possible under laminar flow hoods. How many of us have laminar flow hoods above our heads in our OTs? Okay, so you're lucky. So now these are the action levels which 797 chapter tells us that if you have more than 1 colony forming unit in the settle plate method in your OT, you have to take remedial action. So that is how strict the conditions need to be. What they recommend is that you should use the first step. You should do all aliquoting or multiple use under a laminar flow hood, and you should use the first step. That is, there should be no obstruction between the laminar flow of air and you. The smoke in that, the red arrows, the smoke is just for demonstration purposes. So what they mean to say is from the exit of the air to your site of aliquoting, there should be nothing else. The glove tips, even when you are using glove tips, the glove tips may not be totally sterile. Even though it is labeled as sterile, it's only a reduction in the number of counts of colony forming units. So they recommend that you wash your hands with isopropyl alcohol after wearing the gloves. The glove tip should be washed, and the glove tip culture should be less than 3 colony forming units. Only then you should, then you can ensure this thing's ability. The guidelines set in the Indian Journal of Ophthalmology in 1993, there was an article which said that up to 10 colony forming units per cubic meter square is acceptable in ophthalmology. So you can see that how far away we are from the ideal conditions. So coming to the protagonist. So this is the vial that most of us use in the US. A lot of people, and especially compounding pharmacies, use the larger vial, the 16cc vial. We use the 4cc vial commonly. Now, before you take anything out from the vial, you basically need to make sure that your route of going into the vial is absolutely clean. It can only be disinfected, it cannot be sterilized. So what we routinely do is that we take a swab dipped in isopropyl alcohol, we clean the top, we make sure we wait for 1 minute for it to dry. Then we use a betadine soaked swab and again clean the center of that. There is a small circle in the center. We make sure even that is clean and again wait for a minute of contact time, and only then do we use the vial. Now this is something which is very important that I wanted you all to take note of. The assistant gives me holds the vial and gives me the drug to load. So when we load it is this way, with the vial on top and the syringe at the bottom. But once I have withdrawn the drug into the syringe, I don't pull out the syringe, because when I pull it out, air will bubble. This is not sterile air. Air will bubble through the drug. Okay, so there is a higher chance of contamination. So I turn the vial around and then withdraw the syringe so that the air compartment is separate. The external air does not have to go through the drug into the vial. So that is something that you need to take note of. Once I've used the vial, I will go to the aliquoting part a little later, but once we have finished either aliquoting or single puncture multiple times, we don't just keep the vial back in its container. I make sure that I have cleaned the vial top with isopropyl alcohol, again make sure it is dry, and then seal it so that there is no contact with the outside air. Remember, when you are using multiple punctures, this is the most, there are only 2 sources where bacteria can get into the vial. One is if the top is not clean, the other is when if the air quantum of bacteria or coliforming units in the air is too much. Now, if the vial needs to be transported, several of us may be going from one center to the other, or even inside the hospital from one to the other. If you want to transport the vial, it has to be kept cool in gel packs. These gel packs are usually kept in the refrigerator at -20. When you keep them in a thermocol box and then you store the vial, make sure that the vial is not in direct contact, because then the vial temperature goes down to up to -20 degrees. There are studies which have shown that that can cause this aggregation into the larger molecules. So I keep it in a separate box. I keep the vial in its box, into a separate box, into the gel pack filled box. Now when you are planning to aliquot into several syringes at one go, it is ideal to have a laminar flow board. The other option is that you have a laminar flow OT and you take up this task as the first thing in the morning, before too many people enter the OT and before the colony count of the air increases. What we usually do is that we pre-sterilize pouches and then keep them in the sterile trolley. Once you have loaded a syringe, we put this into the sterile the pouch. Now see, the sterile pouch is open at one end from where you have introduced the syringe. So the external air can always enter there. So what the system that we have is that if this is the pouch in which the syringe goes, we have a separate larger pouch into which we introduce this with the open end this side. So there is a measure of closure. Okay. The other thing which we have recently started doing, we were initially afraid of doing that, but maybe it was just a thought block, is that, I'll go to the slide first. Once we do this, we store it in a sterile box. Now, what we have started doing is that those of us who have ETO, they have these heat sterilizers for ETO to seal these pouches. Now, usually that is kept outside the OT and it is unsterile. So, initially we were afraid of taking the syringes there and then sealing these pouches. what we have done is that the day that we decide that we are going to sterilize, we are going to aliquot the syringes, we bring that sterilizer machine into the OT the night before and then use formalin so that even that machine is clean. So the minute we get the thing sterilized on the trolley and say 10 or 20 or how many ever number you want to, the number of syringes are ready. The same guy who's clean and draped, he goes, scrubbed and draped, he goes and does the sealing inside the OT itself. So that is a measure where you can ensure a very high degree of non-contamination. Now I'll come to this mini spike kit. Now it's not available in India, but those of you who have friends abroad or who go and come, they can get a lot of these. This is a very useful thing. This can be fitted to the top of any vial, and once you draw drug from this vial, the air that goes in this particular mini spike, there is a small micropore filter through which this air goes in. So only sterile air is allowed to enter the vial. So this is very useful when you are aliquoting. Now, how the next question comes is, once you have aliquoted it or once you have opened a new vial, how long can you hold? There are studies which have shown that there is an exponential growth of organisms. If you have only 10 organisms at 6 hours in a new vial, if you keep it at room temperature, at the end of 24 hours, you would have 7 billion organisms. So that's a huge inoculum if you are going to want to reuse it again. Of course, this is much less when you keep it at 4 degrees centigrade because 4 degrees does not support that active replication of bacteria. The FDA currently recommends that if you are refrigerating a bottle open vial or say these aliquots, you can keep it up to 14 days. That is the first low. This is a sterile vial, so it represents a low risk. You can use it up to 14 days once you have aliquoted or once you have opened the vial. Now the FDA guidelines say that if a single dose vial is used and opened a punctured vial, and that too in an ISO 5 environment, it can be used only up to 6 hours. And if it is worse than ISO 5, you have to finish it off in 1 hour or throw away the vial. What is the existing practice in India? Our RedNet survey showed us that up to 45% of us use a vial, open vial up to 1 month. So far away from ideal, but that's the reality. Now coming to microbial contamination, there have been several reports of outbreaks of infectious endophthalmitis after using the Avastin from compounding pharmacies or from single dose vial. But if you see the whole, if you summarize all the reports that are there and you see carefully, there are 2 reports that I want to point out, the Pacorus report and the one by Lee et al., the last one, where they had, the reason I've highlighted these 2 reports is, these were places where some people used aliquoting and some people used the single dose vial multiple puncture technique. Almost all the cases of endophthalmitis that have occurred have been from the aliquoting technique, especially from the compounding pharmacies, and only a very, very small number have been from using the single vial multiple puncture technique. There are a couple of studies in the literature which very good studies. One we had performed on our own, where they have studied the effect of a vial opened under clinical conditions, not the ideal lab conditions, but under clinical conditions, and then studied the stability of the drug, the stability of the vial, and the efficacy of the activity of the bevacizumab at 1 month, 3 months, and 6 months after opening a sterile vial, repeatedly drawing the drug at these intervals, and they found that there was no difference. The drug was stable, it was sterile, and it was very efficacious. In our own study, what we did that once we used the vial for 1 month, after that we used to keep it aside, we never used to discard it, and then at routine intervals, weekly for 3 months, we would draw just like take it to the OT, take a vial and send it to the microbiology lab, and then we would ask them if anything grew. So in the 32 samples that we tested, we found not a single culture had any growth. Now coming to the clinical effect, the Retina India survey, when we asked about 115 retina people on what their experience was, almost 1/3 of them had endophthalmitis in one of their patients, at least one of their patients, after using Avastin. This was more common. So the lower graph, it was more common in people who had more than quantum of injection of more than 12 per week. That is, high volume surgeons have more endo. Lower volume surgeons had less endo. But the surprising thing that came to us was that the safest technique reported in this was the aliquots made under a laminar flow hood. They reported the least, surgeons using this reported the least rates of end-off, and those who were withdrawing from the vial, almost 1/3 of them had an end-off. The sample size was a little low, so the p-value did not reach to less than 0.05, but of course it gives us a trend. And by the way, the highest reported rate of endophthalmitis was seen among those people who were using aliquots made elsewhere in a compounding pharmacy. So that is probably the least desirable thing to do. Now, both these methods, aliquoting and using from a single vial, multiple puncture, have certain pros, cons, and certain precautions. So I just highlighted it in the last couple of my slides. When you are aliquoting into syringes in OT, the storage risk is minimized. That inoculum into the vial and then that growing continuously, that is minimized. It is more controlled, especially if you are using a mini spike pin, it gets even further controlled. You're almost sure that you have a sterile drug in your injection. Whenever you're doing this, do it in the early morning in the OT after overnight disinfection, fumigation or whatever method you're using, because the floating particles which carry the bacteria, the lint, that all settles down. And make sure that not too many people are in the room that you're going to be using this aliquoting technique. Make sure that whatever form of storage you are using, once you've aliquoted into set of vials, is absolutely clean. Now the cons of this technique is that it is highly dependent upon a sterile environment. If you don't have a very good environment and if you don't follow the practices religiously, you can land into major trouble. The multiple puncture technique, the way I use it for up to 8 to 10 punctures over 1 to 2 weeks time. If I finish 8 to 10 punctures in say a week, I discard it. I don't keep it for 2 weeks then. The big advantage is a clock restart. What I mean by a clock restart is that if I have not introduced organisms at the first puncture or the second puncture or the third puncture, till the next, it's not that the vial has been opened from say day 1 to day 7 of use, the microbes have 7 days to grow. The time that they have to grow is the time when I last introduced it. If you have contamination in your syringe during aliquoting and you use that syringe 14 days later, the bacteria are continuously growing throughout that 14-day time. However, if I have given an injection today from a single-use vial and the patient does not, the next day I see the patient is fine, the next time I am going to use the vial, that is the time that I may have introduced the infection. So that 24 hours or 48 hours till the next injection, that is the only time that the microbe has been allowed to grow. The other big advantage I feel is that in a single dose vial, if I take multiple punctures and my patient has an end-off, touch wood, nothing has happened yet, but if it happens, I have the whole vial with me, which I can send for microbiological analysis and get to know what organism was inside the vial. This is something which you cannot do with the aliquoting technique. When you are using this technique, make sure all the steps you do it yourself. The cleaning, don't leave the top cleaning to your assistant. They will not, they don't understand the importance of this. Make sure you do it yourself. I make sure that I even pack the vial and put it back myself. I have shown you some data which says that till 6 months they found it okay. But resist this urge to use it indefinitely and to use it in all sorts of environments. All these were done in OT environments, in clean environments. Not all of us enjoy that kind of a privilege. And the inoculum, the cons of this technique is that the inoculum may be very high if the sterility is broken. So you have to be prepared for a severe end-off. So just to summarize the checklist, always disinfect the vials prior to use. How do you do that? You vigorously wipe the vial top in one direction using a sterile disinfectant and a low-length wipe. Sterile disinfectant is the povidone iodine 10%. Don't use the 5% that we use in our thing. Use the 10%. Allow the vial top to dry prior to penetrating it with a needle. All personnel must use aseptic technique and must be properly garbed. By garbing, I mean full scrub, full surgical wash and scrub like you prepare for surgery. Use sterile gloves and make sure that the gloves are also washed with isopropyl alcohol. And keep the active area wherever you are going to be aliquoting it or you are going to withdraw drug into your syringe, clear of unnecessary items, and try working in first air, that is the freshest air in the OT in the morning. This is a sobering slide. 30% of our retina specialists had end-off. but still 75% were not, 75% of those were not informing patients that endophthalmitis is a possibility. Why I kept this slide here was that some of us try to, I should say, some of us don't learn from the mistakes of others. We try to downplay the risks because we have not had that complication. I think it's essential to learn from others who have had endocs and who have learned from the others and refined their technique, even if it takes a couple of extra steps to make sure that our patient safety is not compromised. Thank you.